I hope we are live. Welcome to the SCTS Virtual Annual Meeting 2021. It's my pleasure to introduce this session on aortic valve intervention, access, and prosthesis option. We'll start the session right now with the first talk of Thomas Modin, TAVI and aortic valve replacement since partner 3, evidence from a surgeon's perspective, randomized controlled trial versus registry data. Thomas, please. Can we have the video of Thomas?
On the event of the STS. So I've been asked to talk about partner 3 and beyond based on randomized controlled trials and registry. Next slide, please. So a couple of months ago, there was a publication in the New York Times following the partner 3 publication also, and the title was "Tens of Thousands of Heart Patients May Not Need Open Heart Surgery Anymore." Next slide, please. So this has changed a lot, the rules, and we already saw a quick shift based on this, on the conclusions of this publication. However, next slide, please. If you look at this study, you would see that there's a lot of doubts. The studies have, like any other study, some limitations, and it has a lot of concerns. But this is an excellent study to start by this. Next slide, please. However, we have been only looking at the glass half full. Let me talk about the limitations first, based on our daily practice. There was the age, I will tell you why. The screening also, I will tell you also why. And the number of concomitant procedures that have been done in the TAVI arms in comparison with the surgical arms. The next slide, please. So there is a lot of confusion between low risk and young patients. So low risk is not young patients. Next slide, please. Only 7% of the patients included in partner 3 had less than 65 years old. So when you know that, on the other hand, in the Western world, the practice of surgery is more than 70% of patients have more than 70 years old, you know that the results of this study cannot be enlarged and applicated in the whole population that we are treating. There is not only confusion, but there is a malinterpretation. Next slide, please. If you look at the eligibility of patients, next slide, please. So the screening itself showed, just for partner 3, that 34% of the patients that have been screened for partner 3 were deemed to be inappropriate for TAVI. But what does it mean inappropriate? 1/3 of the patients was a candidate for a TAVR because of aortic stenosis, but we estimated that they are not a good candidate. Next slide, please. This is where this study is, from Rodescabo team, Canada, is very important. It has been reported recently, and they wanted to address what was the profile of patients who were not deemed to be eligible for partner 3. Next slide, please. So we had 4 categories of patients that actually are patients that we deal with every day. The non-track 3-leaflet aortic valve, so this is an anatomical classification. Patient who had aortic stenosis plus severe coronary artery disease. Patient who had aortic stenosis plus concomitant mitral or tricuspid or both valve disease. And patient who needed a concomitant ascending aorta replacement. And if you put all these patients together, it's almost more than half of the patients that were referred for aortic stenosis initially. Next slide, please. And if you look at the data, when these patients have been operated, except the patients who had this anatomical variation with the actually bicuspid, mainly the NTAV, all the others, if you could see, you look at them, they had a more mortality in the surgical group than in the TAVR group. But this is obvious because in some patients, you needed to achieve concomitant mitral and tricuspid, and if you don't do it, you are not treating optimally the patient. Some patient has severe coronary artery disease, so they needed much more concomitant CABGs, and this also increased the risk. And some others had needed, because of ascending aorta dilatation, they needed to have concomitant aortic replacement, although there was no difference between TAVR and SAVR. So you see, there is, how do we say, a kind of protection. This study was designed to have the best outcomes when TAVR patients were indicated, which is very good, but that means that we cannot replicate this, applicate this in daily basis, in real life, every day. Next slide, please. So let's go more into details with this study, partner 3. Again, next slide, please. 8% of patients in the TAVR group had concomitant PCI, 35 in the surgical group, and they have had different type of surgery. Some concomitant procedures were easy, some others were much more difficult, as we have seen it before. Next slide, please. So this could explain sometimes the difference between TAVR and SAVR in the partner 3. So let's look at the concerns that I have mentioned. First of all, next slide, please. The paravalvular leak, but we will talk quickly about PPM. The bicuspid, we have mentioned this. The pacemaker, which is very important because we want to, the partner 3 is pushing the indications toward low risk and younger patients. This is very important. The subclinical valve thrombosis. What if this happens in younger patients? And of course, long-term durability. Next slide, please. So paravalvular leak. Next slide, please. I will go quickly. I mean, partner 3 have shown that S3 valve is a very efficient treatment for aortic valve stenosis with fantastic results. As you can see it here, the majority of patients have none or mild paravalvular leak, where in surgery, we have almost no patients with paravalvular leak. Next slide, please. Why is that important? It is important because if immediately after the TAVR procedure, there is no impact on mortality, we have to be careful about what could be the consequences on long term. And long term, it doesn't mean 1 or 2 years. Long term, it means much more, especially in younger patients. So you see here clearly that if you have moderate to severe paravalvular leak, which was not the case with the S3 and partner 3, there is an increase of mortality in comparison with mild to moderate. But again, we're not talking about 6 months, 1 year, or 2 years. Next slide, please. Look, the importance of this minor paravalvular leak on the long term is could be explained by this study from Azadani, energy loss due to PVL with transcatheter aortic valve implantation. Next slide, please. And in conclusion, they say that substantial energy loss during diastole occurs due to TAV paravalvular leakage. In the presence of even mild paravalvular leak, TAV implantation imposes a significantly higher workload on the left ventricle than equivalently sized surgically implanted bioprosthesis. This is a very important feature, something that we have never been looking at in surgery because we don't have it. But here we have to observe it very carefully in the TAVR group. Next slide, please. If we look at the differences in left ventricular remodeling, so of course we are supposed to talk about partner, but this is very important. This is another study from the core valve prosthesis. Next slide, please. In comparison with surgery. Next slide, please. I will go quickly here. So you see, in conclusion, they say that at midterm follow-up, the presence of paravalvular leak is associated with worse survival if you do a TAVR versus SAVR. So again, if you have a paravalvular leak which is noted to be impactful, this could have impact on worse outcomes. So we have to keep this in mind and select patients carefully. This is what partner 3 did, but also again it means that we should not extend it to all the population. Next slide, please. So this study showed clearly that the survival rate was lower in the TAVR group than in the SAVR group because of the paravalvular leak. Next slide, please. Pacemaker is not a minor issue. This pacemaker is a very important issue. So we all know that with this balloon expandable valve, the rate of pacemaker is lower. Of course, it turns around 6% of patients. However, we are ignoring that 6% of the patient, giving the expansion of the indications could have a major impact medically, but also socially and economically. Never forget that any external compound that you put into the heart can lead to endocarditis. Next slide, please. So mortality and heart failure due to conduction abnormalities, next slide, please, has a major impact. This recent study shows that if you have no conduction abnormalities, the survival rate is much better than if you have had new PPM, but also a new bundle branch block. This is a very important feature that we have never been looking at before. Next slide, please. If you look at this, all causes of mortality, again, if you don't have at 1 year, since 1 year, no conduction abnormalities, you don't have an increase of the mortality rate, but if you have a pacemaker or left bundle branch block, you have an increased mortality at 1 year. Next slide, please. So what about left bundle branch block? The same study, partner 3, shows clearly that the occurrence of left bundle branch block is more than 20% in the partner 3 trial. So we don't have a pacemaker, but we have the new onset of left bundle branch block. Next slide, please. So why is it important? The impact of new onset left bundle branch block and peri-procedure, of course, pacemaker, has definitely an impact on TAVR. So this is a systematic review and meta-analysis from the same team from Canada. Next slide, please. And it shows the following. Whenever you have a left bundle branch block, you could worsen the outcomes. So you have a higher tendency to be likely being implanted by a pacemaker. It's also if you have a left bundle branch block. If you have a left bundle branch block, you also have an increased risk of cardiac death at 1 year. If you have an LBBB also, you have an increased risk of mortality of all cause of death at 1 year. So this is something that we should not ignore. Of course, technically things have been improved and now we can implant balloon expandable TAVR. We're using S3 device, using this cusp overlap and reduce this amount of left bundle branch block. But this was not reported with partner. And this is something that we have to be very cautious about because technically this is not diffused worldwide yet. Next, please. The mismatch, of course, is very important. Next slide, please. The number of patients with mismatch, severe is very low, but moderate is really consistent if you look at it. 53% of patients have it in TAVR group. We have it also in the surgical group, but it was existing in the TAVR group. But we used to ignore it. Next slide, please. I don't think that this is a minor problem because we know it from surgery. Of course, we have to be careful about the interpretation of the numbers and the way that the echocardiograms have been done at that period of time of this study, for example. But it shows clearly that we cannot ignore the presence of patient prosthesis mismatch, and we have to make a better selection of patients that also TAVR devices. Next slide, please. So it makes no doubt to anybody that if you have moderate, I'm not talking about severe, it also could worsen the outcomes, and patients who have no PPM are doing much better. Next slide, please, in terms of survival. Subclinical valve thrombosis. This is something we knew with the surgical experience, but it disappeared over time. But now we have to face it with TAVR. Next slide, please. And you can see it. This is not a minor issue, you know. It could, and also the problem, it's usually silent. It could be only discovered by an increase of gradient. And sometimes it disappears with anticoagulant treatment. Sometimes it does not disappear, and this could lead to valve early degeneration. Next slide, please. This is how it looks like when you have thrombosis and the effect of, in some patients, antiplatelet therapy or anticoagulants. Next slide, please. So the subclinical leaflet thrombosis in transcatheter and surgical bioprosthesis study extracted from partner 3 shows the following. Next slide, please. Next, please. You see, it shows clearly that there is a subclinical leaflet thrombosis increase in the TAVR group in comparison with the surgical group. And this is not only in the early days after the procedure. It could appear, or it could last despite different treatments at 1 year. And you see the number is increasing. Of course, if you don't look at it, you don't see it, you don't find it. But what could be the consequence of this halt problems on the TAVR or the surgical group? This could lead to early failure, and we have not to ignore it, especially in young patients. Next slide, please. So should we anticoagulate low-risk patients with the inherent related complications? This is something that we have to question ourselves with. And before enlarging the indications of TAVR, be careful about whom could benefit of it and whom could not. Next slide, please. Long-term durability, next slide, please, is a very important issue. And this is where now I would say the debate is placed. So this is a study published not very recently, actually, but it has its importance. Next slide, please. This shows clearly that if you use a bioprosthesis and you know that the failure occurs after 10 years, the break point is at 10 years. It's not at 2 years. It's not at 5 years. So any publication reported today with partner 3, with partner 2, but also Notion trial are still behind 10 years old. So there we cannot expect anything out of it. We know that the mechanism is not the same, and everything that this threshold is at 10 years. Next slide, please. Next slide, please. Okay, so you see it here. If you compare them, this is for partner 2. SAVR versus SAPIEN of the curves, and this is surgery. With the SAPIEN 3, we're still not there, but it's too early to state anything because we're still not at 10 years. Next slide, please. All cause of bioprosthesis valve degeneration. This is also very important, and it confirms what I've been saying. This is a new publication from Philippe Barrault team, Canada again, extracted from TAVR, from partner trials. So with SAPIEN XT, which was doing not as good as surgery, and also with SAPIEN 3. SAPIEN 3 or surgery, we're still doing a comparable, I would say, over time. But again, we're still far behind the 10 years that we're talking about. And the results are not as good as they were with the SAPIEN XT. So that's why also this is the confirmation that we have to be very careful before expanding the trials. So I would say next slide, please. This is my conclusion here. Partner 3 trial is a fantastic trial. It showed that TAVR is very effective and safe. However, partner 3 trial, which shifted also and influenced the publication of new guidelines, was not addressing all patients. So this is very important. It took a picture of what is the optimized, the best profile for a patient with aortic stenosis to get the best benefit of a SAPIEN 3 implantation. But that does not mean that all patients with aortic stenosis should benefit of a SAPIEN 3 implantation. Thank you very much. So I'm done with my presentation. We're gonna go quickly now, and it's my pleasure and honor to present the next speaker, who is my friend Laurent de Kerkhove from Belgium. He's an eminent surgeon with a lot of experience in aortic valve surgery. Laurent, it's your turn.
Ladies and gentlemen, dear colleagues, it's a pleasure to give you this presentation at the SCTS UNESCO University 2021. I have been asked to speak about redo aortic valve surgery. Is there a need? I have no disclosure. Those are the different indications for redo aortic valve surgery. Bioprosthesis, structural or non-structural valve deterioration, mechanical valve non-structural deterioration, of course, prosthetic valve endocarditis, including in TAVI, after TAVI, failure after valve sparing or aortic valve repair or Ross procedure. Those failing can occur due to regurgitation or stenosis, and after ROS, it can occur because of autograft dilatation. During the late 90s and the 2010s, the rate of bioprosthesis over mechanical valve has incredibly increased in most of the patient age population, especially in the age population of 55-year-old and above, where majority bioprosthesis were used because of the new anti-calcification treatment applied on this third generation bioprosthesis, the one we are using today. Because of that, patients, relatively young patients and older patients with bioprosthesis are common nowadays, and many have their bioprosthesis who failed due to structural valve deterioration by leaflet calcification or tear. And in this population, of course, since TAVI exists, the valve-in-valve has been tried and is now become a common treatment for these indications. So the aim of this presentation will be certainly to see and compare the results of surgery versus TAVI for redo aortic valve surgery. So since the early 2020s, we have seen the rate of TAVI increasing, first becoming more frequent than the mechanical valve, and since 2015, more frequent than the bioprosthesis. In the STS database, also the number of TAVI has exponentially increased over year, becoming more frequent than isolated surgical aortic valve replacement since 2015, and since 2019, TAVI is more frequent than SAVR in all its form. Within the huge load of TAVI, valve-in-valve represents approximately 7% nowadays. So it's good to have in mind what is the burden of redo aortic valve replacement compared to a primary aortic valve replacement. So in this study from the STS database that includes more than 57,000 patients with 3,380 redo surgeries, they observed that the operative mortality was twice in the redo compared to primary surgery. Also, the composite operative and major morbidity was doubled in the redo surgery compared to primary. And other outcomes like renal failure and permanent pacemaker implantation were also twice as frequent in redo surgery compared to primary aortic valve replacement. When they look specifically redo surgery in patients having bioprosthesis, because this is the population that will be compared to TAVI, valve-in-valve, there is a similar higher operative mortality, composite endpoint, composite outcome, and higher rates of renal failure and pacemaker in the group of patients having a bioprosthesis in place. So since year of two, we have available in the literature long series, big series with some follow-up of patient having valve-in-valve. So this is the one-year result from the prospective VIVA post-market study containing 200 valve-in-valve, principally with the Evolute Air TAVI, which is self-expandable TAVI. The mean age was 80 years, mean STS score was 6.6. 42% of the patient had a bioprosthesis of 21 millimeter or lower. The 30-day mortality was 2.5% only. There were 3% stroke, 8% pacemaker, 7% major bleeding, 2% coronary obstruction, and 7% vascular complication. At 1 year, mortality reached 9%, stroke doubled from 3 to 6%. There were 10% pacemaker, 9% pacemaker, so nothing much more than after 30 days. 1 or 2 cases of coronary obstruction during the first year, and very few more than mild AR. So quite a good result at 30 days and 1 year post valve-in-valve. Notably, there was a good decrease of the gradient postoperatively, but we observed that the mean gradient was reduced to 21 millimeter of mercury in average in the small bioprosthesis compared to 15 millimeter in average of mean gradient postoperatively in the bioprosthesis greater than 21 millimeter of size, of label size. And this was stable at 1 year. Now the 3-year outcome after valve-in-valve from the Partner 2 registry show in 365 patients with a mean age of 79-year-old, STS score of 9%, 32.7% all cause of death after 3 years, 6.2% stroke at 3 years, and only 2% aortic valve reoperation after 3 years. Again, the gradient was decreased significantly by the valve-in-valve to an average of 17.7 millimeter of mercury post-op, which was stable over 3 years period. Interestingly, the mean gradient decreased less when the indication was bioprosthesis degeneration by stenosis than compared to regurgitation. And by deeper analysis, it was observed that the bioprosthesis that degenerated with stenosis by stenosis process are more prone to be the smaller bioprosthesis compared to the one having a degeneration by regurgitation, inducing regurgitation. So it may reflect the fact that here you have more small bioprosthesis than in this category of patients. Also, bioprosthesis developing stenosis may have thicker leaflets with lesser expansion of the TAVI in size, and so a higher residual gradient than bioprosthesis that present leaflet tear and regurgitation, that may have leaflet that stay thinner than in the stenosis. Now, in this study from the Mayo Clinic, comparing the outcome of 350 redo patients operated between 2008 and 2018, 99% 90 had valve-in-valve, 260 had redo surgery, no matching. Patients with TAVI were generally older, with a higher STS score than patients having redo SAVR. The mean time to repeat procedure was 7 years. There were similar rates of prosthesis of 23 millimeter or below in both groups. Root enlargement was performed in 17% in the redo SAVR. The procedural complication was twice as high in the redo SAVR compared to valve-in-valve. The operative mortality was similar in both groups. Interestingly, they evaluate at 44% the rate of severe patient prosthesis mismatch in the valve-in-valve compared to 12% only in the redo SAVR, which is 4 times as high in the valve-in-valve. The survival at 3 years were a little bit better in the redo SAVR, but patients were younger in this group with lesser STS score. So then conclude that valve-in-valve and repeat SAVR can be done with similar operative and intermediate term mortality. SAVR result in better hemodynamic function and thus appears to be the preferred option. After this paper came some others. Here a paper comparing in a match comparison 49 valve-in-valve compared to 83 native TAVI. So to see if the valve-in-valve presents a higher mobility than the native TAVI. The mean age was 83-year-old, mean STS score 5.2. 79% self-expandable valve were used in this cohort of patients. Mortality and most complications were similar for valve-in-valve compared to native TAVI. Coronary occlusions occur only in valve-in-valve in this study in only 2 patients, which represent 4.1%. Interestingly, the need of pacemaker was much less after valve-in-valve compared to TAVI in native aortic valve, probably because the stent of the degenerated bioprosthesis protect against the damage by the TAVI of the conduction system that is present in the TAVI native valve. Also, interestingly, the residual gradient was higher in average after valve-in-valve compared to native TAVI. There were 4 times more patients with a mean aortic gradient above 20 millimeter of mercury. There were similar paravalvular leak after valve-in-valve compared to TAVI. The first meta-analysis show mainly between valve-in-valve and redo SAVR out of 6 observational studies, lower pacemaker implantation after valve-in-valve, more paravalvular leak after valve-in-valve, and more major vascular complication after valve-in-valve compared to TAVI. All other endpoints were similar between the 2 procedures. A more recent meta-analysis show out of 12 studies combining more than 16,000 patients that valve-in-valve is associated with lower rates of 30-day mortality, stroke, permanent pacemaker implantation, major bleeding compared to redo SAVR. But valve-in-valve is associated with higher rate of myocardial infarction and severe patient prosthesis mismatch compared to redo SAVR. Of course, the length of hospital stay was in favor of patients with valve-in-valve. Now, another study representing a nationwide experience of valve-in-valve compare patient with valve-in-valve compared to redo surgery. Out of 4,000 patients operated between 2010 and 2019, they matched those patients with 700 patients in each arm. What they found is that the all cause of death, the cardiovascular death, the major clinical event were all almost twice as high in the redo SAVR compared to valve-in-valve. So major reduction of all those outcomes in the valve-in-valve. Only the pacemaker, permanent pacemaker implantation was 3 times higher in the valve-in-valve compared to redo SAVR, which was not observed in the other comparative study that I've presented you. This is specific to this study. Now, the long-term outcome in this study show similar rates of combined endpoints between valve-in-valve and redo SAVR. This combined endpoint includes cardiovascular death, stroke, myocardial infarction, and re-hospitalization for heart failure. Similar all cause of death at 4 years. There were significantly less re-hospitalization for heart failure in the group of redo SAVR, and there were less pacemaker implantation also in the group of SAVR. In this study, similarly, we compare valve-in-valve to redo SAVR. It is the experience between 2008 and 2017 of the state of Ontario, Canada. Combined includes 560 patients which are matched with 131 patients in each arm. They find also that the length of stay was doubled after redo SAVR as expected. The 30-day mortality was decreased by 7.5% after valve-in-valve. Pacemaker were reduced by almost 10% after valve-in-valve compared to redo SAVR. The survival at 5 years was just significantly lower after redo SAVR than after redo valve-in-valve. The other outcome, cumulative incidence of late all-cause readmission was not significantly different, and freedom from late MACE was not significantly different between the two groups. Now, last study comparing the valve-in-valve in stentless versus stented bioprosthesis. This registry show that it is more difficult to perform valve-in-valve in stentless because of lack of fluoroscopy marker. They observe more failure with regurgitation, more malpositioning of the TAVI, and the need of second TAVI, more paravalvular leakage after TAVI in a stentless, and more coronary obstruction. But at 1 year, the survival was similar in both types of valve-in-valve in bioprosthesis. So in conclusion, certainly the valve-in-valve is becoming the standard of care to treat bioprosthesis structural valve deterioration in elderly patients with moderate or high surgical risk. The issue in valve-in-valve is the risk of patient prosthesis mismatch issue that can eventually be solved by the procedure of ring fracture with the TAVI before TAVI implantation to increase the annulus size, or by using the new bioprosthesis with a cuff that is eventually expandable during TAVI implantation. Now, the other cause of redo, like stenosis after valve sparing or valve repair, here TAVI has already been shown to be feasible, and it looks like a TAVI in a native valve. Redo SAVR for bioprosthetic structural valve deterioration is still preferred in young patients with low surgical risk, especially if they present small bioprosthesis, because they will have lower risk of severe mismatch if they are reoperated with a bigger bioprosthesis, and if they have received previously a stentless, like a freestyle bioprosthesis. All the other indication for redo SAVR are not appropriate indication to use a TAVI, or TAVI were not tested in those indications. So the response for the initial question is yes, certainly will still need experimented surgeons for complex redo aortic valve surgery. Thank you very much for your attention, and it's a pleasure to participate to this meeting. I hope you can hear me. It's my pleasure to introduce the next speaker, Marco Solinas. Just before to start this talk, I would like to encourage the participants to rate the presentation on the poll. We will have a Q&A discussion at the end of the session, so don't hesitate to ask your question, and we will address them at the end of this session. So next talk is on aortic valve replacement, time to abandon conventional sternotomy, by Marco Solinas. Thank you, Marco.
Good morning, everyone. My name is Marco Solinas. I'm the chair of the cardiovascular department, Fondazione Monasterio, Massa, Italy. I'm one of the co-founder of the Endoscopic Cardiac Surgeon Club, a group of enthusiastic surgeons, endoscopic surgeons, that really believes that endoscopic surgery can make us a better surgeon. You are more than welcome to follow us on Twitter. The topic that the society gives me is very interesting. Is minimally invasive isolated MDR, from niche to routine. It's time to abandon conventional sternotomy. Well, for this, minimally invasive is not only a technical issue, but it's also, we can say, a philosophical one. In Japan, they have a great philosophy that is called Kaizen. That means that as human beings, as surgeons, we have to improve every day. Also, just a little bit, just a step forward, but every day we have to improve. And the minimal invasive is all about that. The idea to reduce the trauma and to use minimal invasive approaches is not new. And already more or less 30 years ago, there were many different options proposed, but to say that of these approaches, just two survived at our time, that are partial sternotomy and mini thoracotomy. The benefit of minimal invasive approaches are already known because there is an improved post-operatory function to the sternal preservation, reduced blood loss, that means reduced blood transfusion, faster recovery, reduced risk of infection. We have to say also a better comesic scarring, reoperation facilities. And those that until, I have to say, 10 years ago were seen as secondary endpoints, in my opinion, nowadays, in 2021, in which the mortality of an isolated AVR is so low, should be considered primary endpoints. We have to move from the comfort zone of the surgeon towards the comfort zone of the patient, because mortality is not, let's say, an issue anymore. And if you want also to speak about hard point like outcomes, we have to say that from recent data published from experience of very large centers like Leipzig, they prove that there is a benefit in survival, not only in the post-operative period, but this better survival in the patient that receive a minimally invasive approach can be found also at 5 years and 8 years follow-up. So yes, there is also a better survival using more invasive approaches. In Massa, and because I have to say the truth, I cannot see a single reason why not to use for an isolated AVR a partial sternotomy. That for me it's, let's say, an obvious approach for isolated AVR. My topic will be more focused on minimal invasive anterior thoracotomy or mini thoracotomy, that in my opinion is my center is the preferred approach. But to understand which was our journey, we have to start from the beginning. At the beginning, this experience started in 2003. We were very, very selective regarding the patient. No reoperation, look at the chest of abnormalities. If there are severe aortic calcification, it's better to avoid small aortic root, bicuspid valve, and etc. And we found, let's say, 3 rules making a CT scan to every patient to select the better patient to that can deserve this approach. And you can see that this is one of our first video. This operation was technically quite demanding. The harvesting of the aortic native aortic valves, but mostly the stitching. And this was a very step-by-step operation in which every single stitch allows you to see the other one. So we published after a few years our first series, and we found that at that time this was a technically demanding operation with prolonged cross-clamp time and CBP time, and also we know how cross-clamp time is important for the outcome of our patient, and with a steep learning curve. So at the end, we found that this technique was for the few and not for the many. This operation was for few patients, very selected, but also for few surgeons. The surgeons should be very experienced and skilled. But we were quite lucky because in 2010 there was, let's say, the sutureless revolution, starting from the enabled and perceval and then intuitive. And the promise of those prostheses was to simplify minimal invasive approach to reduce cross-clamp time. From the beginning, nowadays we have also other devices that can help us in performing this operation if we cannot use sutureless technology. There is Cornot, the RAM device, and we have also the possibility to have a better visualization of the operatory field thanks to the 3D endoscopes. From the beginning, we were fanatic, let's say, enthusiastic about sutureless technology. We started with Enable, that then was taken out from the market, and now we use mostly, obviously, Perceval and Edwards. And we have implanted more than 1,500 sutureless and rapid deployment prostheses. And we have performed more than 1,000 mini thoracotomy, and in the 60% of this operation we have used sutureless, and in 39% we have used sutured prosthesis. If we split the period into prior the advent of this technology and after the advent of this technology, you can see which was the tremendous impact of this technology in our practice. Prior to the suture technology, the minimal invasive approach were used only in the 40% of the patient due to all the reasons that we have stated before. But after, with the introduction of this technology, 9.5% of our isolated AVR are performed through a minimal access. One of the things that is really help us and getting better and better is the imaging. And I think that is mandatory nowadays to do a CT scan to every patient, because the CT scan can give you the possibility to plan your operation from the beginning, where to cannulate, which is the right intercostal space, which is for that patient the best approach, more anterior, more lateral, axillary, and whatsoever. And on the basis of all those, you can use the two approaches that we're using now, that are or the anterior thoracotomy or the axillary approach. That is different also, in my opinion, about the prosthesis that you want to use. So this is what we are doing nowadays. This is a right anterior thoracotomy. We perform a thoracotomy about 5 centimeters using a soft tissue to engage the soft tissue of the thorax, and most of the time we use also a small retractor to have the visualization. The patient then is put on bypass to the femoral arteries. The custodial most of the time is performed. The aortic is the aortic valve is taken out, and the decalcification is performed as usual. This is something that we have understood from the early beginning, that for this prosthesis, for the Perceval, but also for the intuitive, it's mandatory to have an annulus that is clean as possible, and more or less in the same way that we do when we have to use a standard prosthesis. Also, we have to remember that if for any reason we are not able to implant a sutureless valve, we have to be able to stitch a standard prosthesis. So when we have placed the guide wires for the Perceval in this video, the only thing that we have to do is to advance the prosthesis in place, to parachute, and then to deploy the prosthesis and check that everything is fine, that everything is okay in terms of positioning, and then to balloon the prosthesis. So with this approach, and obviously not only with Perceval, but this is our data about the mini thoracotomy VR. These are our results in terms of ICU stay, hospital stay, in-hospital mortality, cerebral events, acute renal failure, and pacemaker implantation. The things that I would like to point out that with the use of this technology, we were able to cut our cross-clamping time of 40%, more or less. We went from 86.9 of the sutureless and rapid deployment technology to 50% nowadays. The other thing that we have done, we have checked the learning curve of this technology in the minimally invasive approach using the Kazan curve, and this is published. In our analysis, there were if there is a teaching program in the hospital with a mentorship, the initial experience of a new surgeon has a learning curve that is completely flat. So it is something that is possible. So now in our hospital, this is the situation. This is the time lapse, let's say. In 2003, we have started with this complex procedure with a limited number of patients and surgeons performing the operation. From 2010 to 2020, with the advent of the suture technology, this is a technique that is routinely performed by all the surgical staff. And now we are confident enough. In 2021, we have started our completely endoscopic VR program. And there was an impact also in hospital mortality between the marriage of sutureless technology and minimally invasive approach. I have to say yes. We have to say that if we look at the state database, the mortality from Israeli VR was getting better and better. But also in our experience, in 2005, our in-hospital mortality was 1.6%, 0.7 in 2015, and from 2015 to 2020, we had the chance to add another small benefit in terms of mortality. So, in our opinion, this marriage, the combination between minimally invasive, sutureless, or right, have an impact on improving mortality and outcomes. So, in conclusion, with the new technology, this is an easy, safe, and reproducible procedure with a really flat learning curve if there is a teaching program. This new technology reduces operating time and facilitates minimally invasive approaches for sure, with excellent result, a great satisfaction for the patient. So, my answer is yes. It's really time to abandon conventional sternotomy. Thank you very much, and I will be happy to keep all the questions that you want to give to me. Thank you very much.
So thank you, Marco. Can you hear me now? And apologies for some technological issues before. We now move to the last talk for this morning, which is going to be given by Bart, who is a surgeon in Leuven. And he is going to talk to us about sutureless rapid deployment valves, indications, and the gaps in the evidence. Really looking forward to your talk, Bart. So we will start with yourself now, and just conscious about the time because we need to close with some questions at the end.
Good morning, everybody. My name is Bart Mures from the University Hospitals in Leuven, and it is my job to talk about sutureless and rapid deployment valves in surgery. As you know very well, there are two main valve types available. On the left side here, you can see the Livanova Perceval valve, and on the right side, there is the Edwards Intuity device. Hereby, I also would like to disclose that I am working as a consultant for both valve manufacturers, and I'm involved in both experimental as clinical research for both the companies. Despite the whole evolution that is currently going on with TAVR, TAVR being used in a wide variety of patients, intermediate risk patients, and even in low risk patients, I think there is still an important role for surgery in aortic valve disease, and certainly there's a definite role for sutureless valves and rapid deployment technology within the surgical field. And I give you a few examples of a wide variety of patients that can benefit from this technology. Number one, when you're dealing with intermediate risk or high risk patients, I know in some regions these patients are all considered to be TAVR candidates, but it is my personal conviction that you still can have very good and very decent SAVR surgical outcomes, certainly when you are using this sutureless technology or rapid deployment technology specifically in these fragile patients. Number two, when talking about isolated AVR done in a minimally invasive way, either to a mini sternotomy or to some variation of a right anterior thoracotomy, and there are many possibilities there, then I think that if you add the speed and ease of valve placement using sutureless or rapid deployments, you really end up with very short procedure times, very short CPB times, and you can have a very elegant and nice result. And this is also involving low-risk patients, young patients. Number three, when talking about combined surgery, you can have combinations with CABG, you can do double valve, triple valve, you can do combinations with myectomy, ablation, left atrial appendage closure, and so on. A high variety of combinations is possible. Sometimes in this category, you are dealing with patients with an advanced age or multiple comorbidities. So again, when you're using sutureless or rapid deployment valves in these kind of procedures, you are taking away a big chunk of cross-clamp time, you are shortening the procedure, you're shortening the CPB time, and you can have great outcomes. And number four, but this is certainly a minority of patients, you can use it, and certainly when you have experience in using these valves, you can use it as a bailout in very complex procedures. And for example, in redo after homografts or after stentless valves. There's a definite role for both valve types, but I'm going to be honest, there is of course a learning curve to go through, and there are some tips and tricks to be taken into account, but this learning curve can be short when you have a good guidance, when you listen to things that we have learned during the last years, then this learning curve can be really short. The tips and tricks are related to the level and the placement of the aortic incision. It relates to some kind of judgment of the valve anatomy in bicuspid valves, for example. It concerns decalcification and the extent of that. Sizing and positioning, I cannot emphasize enough that these are the two main critical factors determining success in both the Perceval as the Intuity. If you oversize these devices, you will end up with high pacemaker rates, or you will end up with high gradients in the Perceval, for example. So oversizing is certainly to be avoided. And also the positioning of the valve, of both valve types, is really critical in getting good results. Of course, you need to learn how to visually control the position of these kind of devices, and you need a good TEE control at the end of the CPB run before you wean the patients from bypass. I'm gonna do two parts in this talk. First of all, my own experience and our experience in Leuven is mainly regarding Perceval, and this is nothing to do with any kind of preference, but this is all related to the late availability and reimbursement of the Edwards Intuity in Belgium. We had been doing Perceval since 2007. We had been joining in on a lot of the clinical studies ongoing with this device. But since 2014, we had the full commercial release and reimbursement of the Perceval. And you see what happened to the yearly numbers in my center. It has become really the tissue valve of choice in a wide variety of patients. And since the last 2 years, this is also joined by the Edwards Intuity, which we like to use in our center as well. In adding 2020, we had a total of 961 implants with sutureless or rapid deployment technology, and we just exceeded 1,000 implants earlier this year. If you look at single AVR versus combinations, what do we do with it? Well, about approximately 45% of our experience is single AVR, predominantly done through a mini sternotomy. We have less experience with the right anterior thoracotomy, but you see 55% of these cases are combined cases, and these can be combinations with either CABG. You can do double valves. This is mainly mitral valvoplasty. You can do triple valve with tricuspid plasty also involved, and you can have many other combinations as well. Why do we like the sutureless valve technology so much? Well, when you compare our earlier data, and this is in the meantime published in the Annals in 2020, when we looked at the first 470 patients we did, this is a patient profile at that time that was perfectly comparable to, for example, the surgical arm in the PARTNER 2 trial. Similar STS scores, but look at the early mortality, early stroke rate, and even the 2 years mortality. So I think these are figures who are significantly lower than what is reported in these PARTNER trials. And we have to remind ourselves that the PARTNER trials are there, that they caused the massive increase of TAVR use in a wide variety of patients. So I think you can really improve the surgical result in a wide variety of patients, even in intermediate risk patients, like I show you here. We are in the meantime, we are updating our data. For example, this is an update in 2019, where we had in total 787 of patients with sutureless or rapid deployment valves. And this is in a population with a mean Euro score of 6.3, but still the 30-day mortality was only 3.2 and the early stroke rate was 1.4. And I challenge everybody to look at your own data. It's not so easy to do significantly better than what is predicted by Euroscore 2, certainly not doing like approximately 50% better than what is predicted. And more specifically, when you look at elective cases only, elective minimally invasive single AVR, then we have 164 patients in this category. The mean Euroscore 2 is 3.1, and you can really do this kind of surgery with a very low 30-day mortality of only 0.6%. Of course, as you all know, mortality and stroke are very hard events and very important and relevant for the patient. And I think if you can provide patients, even in an elevated risk profile, in an intermediate risk profile, with this kind of low mortality and low stroke rates, then I think you have a great surgical result. In the meantime, and now I'm talking mainly about Perceval, we have learned how to size these devices. In the early years, the manufacturer told us a certain sizing technique, using the sizers in a certain way. But after a few years and with a lot of experience, we have realized that we were all actually slightly oversizing the prosthesis. And it took us until 2017 to really realize this. And now in the meantime, we can go back into our data and we can really compare the old initial sizing technology. And I have to remind you that many of the initial papers were published using the old sizing method. And we can compare this with the new sizing method that we are doing now since 2017. And you see we have a quite large cohort of more than 400 patients with the old sizing and more than 340 patients with the new sizing. When you really apply the sizing for Perceval as it is mentioned and as it is told and learned now, you can see that you can decrease the peak gradients. In the early experience, there were some reports on elevated gradients early postoperatively after Perceval. And this was really due to oversizing, because if you oversize this prosthesis, the valve leaflets start to flutter, you have a fluttering effect, and you can have elevated gradients. So with correct sizing, we have decreased peak and mean gradients, we have increased effective orifice area and effective orifice area index. But next to that, and this is also equally important, the pacemaker rate. In the early years, we also have seen a pacemaker rate up to 10%. I have to admit, this is in a combination of patients, high age, a lot of CABG, concomitant surgery, multiple valves, and so on. But still, this rate was too high. But now, in the last 4 years of our experience, the actual pacemaker rate of early pacemaker implantation is only 4.6%. And I think this really compares well to what has been shown in other standard sutured valves. So we have learned to size this prosthesis, and I think it's important to take this message through. In the echo follow-up, we are doing, this is data published already in the Annals 2020, but we are gathering more and more follow-up as we speak, because we have some patients running around since 2007 already. Then we see for the moment no real problems with durability. We have, this is a collection of all peak gradients and all mean gradients across time. And as I mentioned, these data are all published last year, but we are updating and new information was submitted now recently to the EACTS with an update on long-term durability in this prosthesis. But I want to be very honest with you and share the complete redo or reoperation rate in this kind of Perceval sutureless valve. And we are talking about an update now in 961 patients. So this is data until 2020. We did 9 redos for endocarditis. This can happen to any kind of mechanical or tissue valve. And we had 6 cases of structural valve deterioration, but this is in more than 3,000 of patient follow-up years. And we had to do 3 TAVRs valve-in-valve inside the Perceval, which I have to mention is perfectly feasible and perfectly doable. The Perceval does lend itself perfectly to do TAVR valve-in-valve if you have a degeneration on the long run. We had 1 surgical redo experience, and we had 2 patients with SVD diagnosis with high gradients, but these patients refused any kind of re-intervention. But this is our total redo experience. So I think for the moment, these are good figures, low durability issues. And I want to remind you that in the meantime, Perceval is being upgraded to the Perceval Plus version with an even advanced tissue treatment inside the leaflets. This is our longest survivor. She was operated in September 2007. So she has now almost 14 years of follow-up, and this is the echo from 2020 with the nice gradients and no regurgitation mentionable. In the meantime, of course, the Perceval valve has gone through a randomized study comparing the Perceval to other standard sutured valves, and this was done in the so-called PERSIST trial, where the goal was non-inferiority, and this goal was really met regarding major adverse cardiac events. There was no significant difference between Perceval and other standard sutured valves, so this can be considered a final proof that you can really use this valve as an equal alternative for a wide variety of patients. But more importantly, a further sub-analysis of this PERSIST randomized trial was shared at EACTS last year, and this was looking at minimal access surgery, specifically isolated valves, minimal access, and there the Perceval showed significantly lower rate of major adverse cardiac events, a significantly lower rate of stroke, and a significantly lower rate of new onset atrial fibrillation after surgery, which is probably related to the lower early stroke as well. And I think this is an important message, because here you don't have non-inferiority, but you have even superiority of this sutureless valve technology compared to standard sutured valves. And I think this is something we really have to keep on doing, and to keep surgery well and alive against the whole TAVR evolution that we are seeing for the moment. Edwards Intuity has been doing very similar things, and like I mentioned, my personal experience is more limited because of the late availability and reimbursement of Edwards Intuity, specifically for Belgium. But I'm going to share with you some very nice experiences from high volume centers. For example, this is a paper from last year from Gunther Laufer's group, who has a wide experience in using the Edwards Intuity. It's a mean age of 74. They are reporting excellent early and late survival data, and also an excellent freedom from any need for reintervention or reoperation. So no major issues with valve durability. Of course, we all know that the Edwards Intuity is very similar to the Perimount Magna Ease, with a similar design and a similar tissue treatment. And we have long-term 10, 15 years outcome in Magna Ease as well. So this is certainly a reliable basis to build upon. In this paper, very low rates of early and late events were mentioned. Like I mentioned, SVD is not an issue for the moment in the Edwards Intuity valve. They also reported very low rates on stroke, ischemic events, on no valve thrombosis, low rates of endocarditis, and acute kidney injury postoperatively. So again, these are examples of elements showing that surgeons who have experience in using this rapid valve deployment technology can offer fast, easy, straightforward operations to a wide variety of patients and have great outcomes in the early and in the late phase. I also want to share with you a paper from this year, again, using the Edwards Intuity device, and this was a propensity matched study, smaller cohorts, but still very validating, because when they compared the outcome, either being a combined outcome, death, stroke, rehospitalization, or a single outcomes, death from any cause or rehospitalization, they found highly significant differences, and this is in a propensity matched patient cohort, significant better outcome with surgical access, surgical aortic valve replacement compared to the SAPIEN transcatheter results. So I think, again, these are interesting results to look at, and this is what we have to keep on repeat on doing within the surgical field. This is an overview paper also from very recently, specifically talking about major complications like stroke, pacemaker implantation, and postoperative paravalvular regurgitation. And you have seen, when you look at time frames going back to 2007, all these rates of these major issues, of these major events, have really decreased tremendously. And also the pacemaker rates, both in the Edwards Intuity valves as in the Perceval valves, have decreased significantly during the last 2 or 3 years of our experience due to the learning, due to the experience that we have had in using these devices in a wide variety of patients. So, are there still concerns in sutureless valves or in rapid deployment valves? Well, migration, certainly not. Migration, there has not been a reported migration after a correctly placed and a correctly sized valve. There have been some case reports of so-called migration, but when you go back into the details of these cases, most frequently this is either a missizing or a malpositioning of the valve in the first place. Paravalvular leak rates, this has been studied extensively, and there are a lot of papers on that. If you do correct decalcification, correct sizing, and correct positioning of these kind of devices, a paravalvular leak is really not an issue. And I have to say, and this is really shown in recent literature, the current rates of paravalvular leaks are, in my opinion, very comparable to what is seen in standard sutured valves as well. The pacemaker rates, I'm going to be honest, they certainly have been elevated during a long period in the first 5, 6, 7 years of use. There have been ranges up to 8, 9, and 10% in some centers. Certainly when you look at the age profile and the combined surgery and so on, it has been certainly elevated. But for both devices, both for Perceval and for Intuity, this is significantly decreasing as we are learning to size, to avoid oversizing, so to size properly and to position this valve really correctly into the annulus, not too deep into the LVOT. When talking about durability, I mentioned that the Intuity is actually very similar to a Paramount Magna East, so you should not be concerned about durability too much, and also valve-in-valve treatment is certainly possible should there be degeneration on the long run. For the Perceval, I have shown you in my data, we have seen very low rates of SVD in our patient profile in our patient cohort. And I mentioned that there is a more advanced tissue treatment now offered in the Perceval Plus version. So I also hope that the use of the Perceval can be extended to the slightly younger patients and can have a good durability there. Also in Perceval, should there be degeneration, valve-in-valve treatment is certainly possible. So in conclusion, when I look back to our experience and to what has been published in the meantime on sutureless and rapid deployment valves, I think these are important elements for the surgeons. I think it is key as a surgeon to have these things in your fingers as well. And I think both Perceval and Intuity have shown to be non-inferior to standard tissue valves. They both make surgery faster and less invasive. The last remaining concern in my mind were really the pacemaker rates, but they are clearly decreasing now, as I have shown you, with proper sizing and certainly avoiding oversizing. From my personal experience, which is more than 13 years of continued use now, we see excellent overall early and late outcome, and I think this is most critical to patients: low stroke rates, low mortality, low rates of dialysis. We have limited SVD. So these kind of technology, both groups of these valves, have really become our valve of choice in a very broad patient population, being either minimally invasive single valves, intermediate risk, high risk patients, combined cases, and also a lot of challenging cases with redos. I thank you for your attention, and I'm looking forward to join the discussion. Thank you.
Thank you very much, Bart. Really appreciate talking. Very nice indeed. So if I could just encourage the fellow presenters and the co-chair just to come live with the camera so we can see you. So firstly, I'd like to thank the 4 presenters, and Thomas, Laura, Marco, and Bart, for excellent talks. Very informative. There are a number of interesting questions that have popped up in the chat lines. Whilst I'd gather the thoughts about who's going to answer which one, just encourage the participants to complete the feedback sessions. So I really enjoyed the talk. So I will take the questions, the order in which they came from. So the first question which was put up was should there be any difference in the outcome if one was to have a paravalvular leak following post-TAVI versus post-surgical AVR, provided you match like for like, i.e. moderate with moderate, trivial with trivial, severe with severe? And if there is, why? So that's the question that has been put up. It's an interesting question. So I don't know who wants to go and try to address that one. Thomas, I think it should be you.
Yeah, I mean, anyone can answer this. The question is, we don't know if we base it only on our surgical experience, because many of us, for various reasons, mainly the calcifications of the annulus, have encountered a post-operative tiny paravalvular leak. Sometimes it led to hemolysis, and sometimes it disappeared alone. From this perspective, I don't know. If we come to these randomized controlled trials, actually it didn't show anything particular, to be honest with you. Maybe it's too early to say anything about it, but it didn't show to have any impact on survival or worse outcomes.
Okay. I'm conscious Lauren's not managed to get his video to work. Hopefully he can join us shortly. Welcome, Lauren. Now we can see you. Anyone else wants to make any comments to what Thomas has said already? So the question was paravalvular leak, surgical paravalvular versus transcatheter paravalvular, and should there be any difference in the outcome? If you get a moderate paravalvular leak, should the TAVR valves patients do worse than surgery or vice versa? What do you think, Lauren?
Well, in my mind, it's our job as surgeons to make sure we don't have moderate paravalvular leaks in the first place. I mean, I think we have some trace paravalvular leaks in complex patients. It can be like 1 out of 4, but I think we really have to avoid that. And this is what is the good thing about the whole TAVR evolution. It's pushing also us as surgeons to provide better quality and better outcomes. So we have to avoid it in the first place and don't have these kind of important leaks after surgery, certainly.
I think that's the ultimate goal. One should leave the theater or the interventional cath lab without any paravalvular leak. That's what we should aspire to, really. Okay, so there are a couple of other interesting questions that I would like to touch upon. So one of the issues that has been flagged up is the leaflet thrombosis with the increased surveillance with the TAVR valves. The incidence has been quoted as high as 20%. Do we think that us as surgeons need to learn something about how we manage anticoagulation following implantation of bioprosthesis?
So this is for me again?
Yes, for you. You mentioned it.
Yeah, exactly. So, again, the same thing. This was a big debate for years in our surgical community. And it ended up... And hello?
We can hear you, Thomas, but you're breaking up intermittently.
I don't know why this is happening.
Okay, I'll come back to you in a second. Bart, do you want to sort of address that one for the audience whilst Thomas tries to link that?
Well, I think it's a very interesting issue, because also in partner 3 you have to know that there is, when you look at the 2-year data in partner 3, there was an increased incidence of valve thrombosis there in the TAVR arm as well. On the other side, we have to keep on looking to what is happening to the surgical valves as well, because probably it's happening there also. For the moment, I still don't see a reason to increase the incidence of putting patients on postoperative anticoagulation with all the problems related to that. But it's certainly an issue worth investigating further. How high is this incidence in surgical valves, and what should we do?
Okay. The connections are a little unstable from Laura and Thomas that we can hear. I'll move on to the next question then. Norman, if you've got any questions or comments, feel free to join in a second as well, because we can see you now. Hopefully you can see and hear us as well.
Yeah, yes, I can. Thank you.
Yeah, great. So I'll ask the question. This was put up by Laura in the comments, actually. There's some data now, re-intervention following aortic valve intervention for coronary specific issues now is an important question with interventional cardiologists always talk about. So Laura has quite rightly put up the paper that is due to come out in JACC very shortly about the revascularization times, with regards to STEMI patients. And there is some data coming along which says that the procedure in terms of catheter to the balloon time is longer with re-interventions following transcatheter versus surgical AVR. Now, in terms of a lifetime context, which is where we're talking about, should that be an important factor in decision-making about what valve is implanted in a 70-year-old, let's say? What are your thoughts, Laura, if you can hear us? Norman.
Yes, I'm not a great fan of the concept of having TAVI for younger patients, full stop, for a number of reasons, and that might be one of them. But I'm not really involved in the TAVI program, so I don't feel suitably qualified to talk about the technical aspects of coronary access. But if somebody is going to, I suppose if somebody needs coronary intervention and it's because of risk factors or whatever, then they're going to have a limited lifespan anyway, compared to somebody who's got very low risk factors who you expect to live for a long time, who probably should be having surgery rather than TAVI. So I know that's not really an answer to your question, but those are my kind of comments about it.
Thank you. So, Bart, what are your thoughts? How would you deal with it in your unit? If the question was asked for a 70-year-old, bearing in mind that a lot of the coronary disease, especially with the transcatheter approach, is being left well alone. So there is a risk, 5-10 years, that a re-intervention will be required.
I have the same concern about. I'm totally in favor of TAVR. It's a good technique. It's a great improvement for many of our patients. But I think surgery also still has an important role to play, and certainly in talking about younger patients or combined coronary disease and all this stuff, we like to have a really balanced heart team decision, and we really like to make a balanced decision for a wide majority of patients. And we are certainly not in favor of this massive dramatic evolution going to TAVR in a too wide range of patients for the moment. But we are learning. There are so many trials that are ongoing. We are collecting data on partner 2, on partner 3, and also on the Medtronic trials. And in the meantime, we as surgeons, we have to keep on pushing the boundaries to lower the rates of major adverse events and to keep on providing great outcome as well.
Okay, so in the interest of time, I think I'll just deal with one more question, and I'm conscious that the feed is a bit intermittent, so real apologies, for that. So one question which has popped up is this valve-in-valve intervention, and Bart, you covered some of it, and previously, it was touched upon by Laura as well. And the question is with regards to the older bioprosthesis. In terms of residual patient prosthesis mismatch and some of the newer bioprosthesis with regards to the externally mounted leaflet, and now with the Inspiris and the residual tissue in the Edwards one, how do you see that in the sort of future arena with regards to 1 or 2 valve intervention for an average, 70, 75-year-old who may, life expectancy is still 10 plus years for a 75-year-old?
Yeah, absolutely. But the main discussion now is much younger than that. When I listen to the colleagues from North America, TAVR is being tissue valves are being used in 40 and 50-year-olds. Even TAVR is being done for the moment there now in a completely new philosophy of doing TAVR first and then surgery later on. So there's so many things ongoing, but certainly for us as surgeons, if we have to keep one thing in mind, if you are patient, please make sure it is a tissue valve that can receive a TAVR valve involved later on. So this means certainly avoiding the very small sizes, and potentially also avoiding the external mounting pericardial devices, because these can have troubles as well on the long run. But like I said previously, and it's a pity that Laurent or Thomas cannot join in this discussion because they have much more insight in these things. But that's certainly to avoid. The small size is certainly for the younger patients.
Any comments from you, Norman? Would a 70-year-old get TAVI in Sheffield?
No way.
No way. Okay.
I think, one thought which I never mentioned in my talk about mechanical valves against tissue valves is that, the general point is healthcare is not the economy. We shouldn't go around, creating demand. As doctors, we should make sure we should try and cure the patient, not create demand. So that's a very, very general point. A 65-year-old, as Bart says, the debate is below 70. And again, I mentioned in my talk, if you look at life expectancy curves in the UK, a 65-year-old man is expected to live in 2021. Somebody who's 65 in 2021 is expected to live 25 years. There's no way that, somebody's not going to end up needing some re-intervention of some description. And I also mentioned the French paper. Now, no doubt people will say, well, those were old devices. The one that was published in JACC, and that was a huge that was a huge study. Comparing valve-on-valve with redo valve. And it's extraordinary looking at, as I said, this was published in a cardiology journal, not a surgical journal. And after 3 years, valve-on-valve was markedly worse than surgery. Deaths, cardiovascular deaths, rehospitalizations, even AF, Now, AF is one of those things that the TAVI people are saying, well, you guys get AF, we don't. But even after 3 years, the incidence of AF and the valve-on-valve had caught and gone beyond the surgical patients. So valve-on-valve as a reason to put a TAVI, valve-on-valve as a reason to put a tissue valve in a younger patient, to me, it just doesn't stand up. We're surgeons. We like something that approaches what you're supposed to have, what God created you with is what you try and achieve. But having a device inside a device, you can see how problems are going to occur. I feel quite strongly about that, which is why I talk about mechanical valves.
Okay, thank you very much. So in the interest of time now, we've overrun a little bit, so I would like to bring the session to a close. Really like to thank the presenters and the participants for their interesting questions. This is a perpetual debate which will go on for a little while, and it's good to be able to get a view. So there is a short break now. I've been told to tell you to stand up, stretch your legs, have a stroll around the exhibition hall, have a look at some e-posters in the networking area, which I've done. And then the next session is due to start very shortly. And my sincere apologies for any technological hiccup that we have had. But this was the morning session, and that's the joy you get by going first. So I think all in all, it has worked. We've heard four excellent presentations. So I really thank the 4 presenters. And hopefully we'll get a chance to interact during the rest of the day. So I'll bring the session to a close, and we'll see you in one of the later sessions today. Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye.